Well, good morning. Well, that video is a really good segue into the idea of patients as partners and patients being informed and taking active roles in their care, which is what I'm going to talk about today. So I'm going to actually talk about the science of self-management. I run an NIH-funded Center for Research in Self-Management for the last 10 years. And I think one of the points that I want to make most today is we teach people, we give people information, but there's a whole science out there about helping people understand what's the information they're getting and take action on it, which I think is mostly what we want with individuals. So I'm going to, I don't know how to advance these. I guess I have to say I have nothing to disclose. But my objectives for today, first of all, I'm going to review just briefly some of the components of self-management interventions. I am going to review briefly the literature. My center keeps up on the latest science and meta-analyses about the effectiveness of self-management. And then I'm going to talk to you about some very recent research that we're doing about tailoring information to patients. In our lab, we're actually looking at brain patterns that people have in terms of how they process information. And what we're finding there is that some people respond differently to empathic information when we reach out to them in ways that meet them where they are in terms of their feelings about a situation versus analytic information. Our approach predominantly is that we pull instructions off of a computer printout before they leave and pretty much give them analytic information. And the research is showing that's probably not the best way to proceed at all. And so I'm going to stand some of our current practices on their head. So just in terms of definition, self-management is the ability of an individual in conjunction with their family and community and healthcare professionals to manage symptoms, treatments, lifestyle changes, and the consequences of chronic illnesses. Although I do extend in our lab, we look at self-management of health as well as self-management of illness. So it incorporates a lot of concepts that we hear about: self-care, self-monitoring, adherence, health behavior change, patient education, collaborative care. And as I said, these can be applied not only to chronic conditions, but acute. Certainly people need self-management after acute procedures, as well as health promotion. So if the purpose is to help people become informed and take an active role in treatment, I just want to caveat quickly that it also includes their decisions about not taking their medications or not wishing to undergo diagnostic procedures, and respect for that and exploration of that with them. And our research in our lab is showing that a lot of times meeting patients where they are and then slowly making small changes toward what we're interested in before we label them as not adherent and not following protocol. Most importantly, I want to say that self-management is a philosophy, a process, and a set of tools. So there's a philosophical stance about having the patient be the center of decisions and collaboration. Some of the basic elements when we think of self-management, there's usually this collaborative definition of the problem. There's goal setting and planning. And then a continuum of self-management skills and guiding people for behavioral change. And now more recently, we really added the idea of providing emotional support because through so many illnesses, it's a psychosocial and emotional process along the way. And then self-management is known for its active and sustained follow-up. It's seldom just a one-time take in terms of our care with patients. I love this particular cartoon because it shows pretty much the self-care is about 80% of the care given in the United States. And yet we have been lagging behind in our science in that area, our application of the science in that area. And I would say its uptake, primarily by healthcare professionals, has been lagging behind in terms of understanding that science and being aware of it. So, living with chronic illness, I like, if you might know, Dr. Kate Lorig is kind of the mother of self-management science. And she's done a series of studies for nearly 30 years now about it. And she describes 3 components of it: managing the illness, managing daily activities and roles, and managing emotions. And actually, in her self-management programs with patients, she starts with managing emotions. That's where they start in all of them before they move on to the analytic activities of your medications and how they work and the side effects and what you should be eating, or managing symptoms along the way. She also includes the managing daily activities and roles. In fact, people come in, their number one concern is ability to fulfill their daily roles, whatever they are in life, as having a job, being a parent, whatever their role happens to be. So Kate Lorig has the most, her model has the most science behind it. The interesting thing about her approach is they're all peer-led, small interactive group, although I will say now they're not all face-to-face. In fact, she has scaled up to have national websites that are peer-led with disease. And then interestingly, she mixes chronic illness conditions. So it's patients with diabetes and arthritis and incontinence, all in the same groups. Because she found out they all have emotional concerns, they all have a set of symptoms to monitor, they all have medications to adhere to, and emotional feelings about that illness. So it's common issues. So I think that's one of the things when we think that we can only do this. I'm very interested as a scientist, not only in finding what works, but what's scalable, so that we can get to patients and get them where they are. This slide shows the contents of her sessions. She has goal setting and problem solving. In fact, her latest research shows that it's not goal setting, it's achieving small goals that motivate patients to keep going and adhere to the regimen that we're asking them to. So what's the secret of that for us as healthcare professionals is help patients set small goals. Between now and next Tuesday, what can you do? Okay, let's work on the journal that you're going to keep between now and next Tuesday, and then we're going to look and see how we would make sense of what you've put in your journal that you're keeping for us. We do not teach self-management like that, okay? Go home, take these meds, do this, do that, okay? We don't help people set goals that are very small and achievable. But if we believe in evidence-based practice, it's clearly the literature is showing short goals that people can achieve, motivate them to keep going. As I'll share with you later in my research on the brain, where we're doing fMRIs, we're actually finding out what those small positive little pings do in terms of oxytocin in your brain and keeping you moving forward on that. As I said, emotional management is a large part of her programs, particularly depression treatment. She attends a lot to exercise and diet, believing that maintaining health along the way, especially in chronic illness, those are important things, and management of symptoms. Of course, they address medication use. A large part of her programs are helping patients manage communication with their healthcare professional. How do you prepare for a visit? What are the things that you should have in mind to take with you? She actually has them rehearse their tough questions to take in and gives people kind of a guideline to prepare for that. In certain cases, they talk about advanced directives. I just mentioned depressive symptoms are an important thing. They certainly go along with so many illnesses today, and if we don't treat them, it's going to be very difficult for people to follow the healthcare regimens that we would hope for them. Quickly now, I want to just talk about some of the evidence today. It's been accruing fast over the last 10 years. First of all, in our recent literature review that we did, we were just looking at, what are the target conditions or diagnoses in which this was by the way, this was a review of the systematic reviews, okay, that we did. And there, as you can see, diabetes is the one that there are the most reviews on. Following close behind are, osteo, asthma, heart failure, some of the ones. Okay. I found only a couple on incontinence in terms of self-management interventions that were effective. So if any of you are out there, it's time to do a good review of self-management interventions for incontinence. That needs updated. Okay. Also, so what evidence do we find by them? I won't go over all of these, but some common things that we see across the chronic conditions are improved physiologic measures as a result of self-management approaches, self-efficacy, or patients' confidence in their ability to manage their disease, and almost all of them, screening behaviors in many. Mortality has only really been studied in heart failure to any extent in terms of the effects of self-management on that, and that has been a positive thing. Medication use, in almost all of them have looked at medication use, and there have been positive results of self-management interventions on them. Quality of life has also been across almost all of the diseases as a positive outcome. I think I just covered that. Okay. In terms of the different interventional approaches, okay, I would say the Lorig one that I gave you is what we would call a comprehensive one approach. And in that, we found 46 reviews, again, mostly diabetes, arthritis, and asthma. Technology-delivered interventions, the meta-analysis of the literature in those are growing rapidly, and I'll say a little bit more about that for us for the future. Self-monitoring interventions, particularly because there were so many on diabetes and oral anticoagulation of those. And then there were a couple interventions called self-management that were action plan interventions, helping people set goals. Now, evidence for technology I want to bring up because I think more and more of us are thinking, how can we scale up? How can we get to more people? Or how can we use technology to help people monitor symptoms? And I noticed that there's a rapid increase in that in the field of continence. So, but there's telephone approaches, telemedicine approaches. Web-based interactive are some of the most popular ones in terms of scaling up. And this is particularly true when people are trying to put together kind of a focus group approach where they create groups of people who have similar diagnoses who will support each other. Cell phone and text messaging, literature is still out on that. Most of the studies have not been good randomized trials yet, and I think I see them at NIH coming through, and my guess is that those will be getting the big trial data soon about the effectiveness. Most of them now are just very small studies. Okay. So in terms of the literature, the research base supporting self-management interventions is large and growing. There are some gaps in terms of target conditions, and I'm saying I think continence is one of those, or selected outcomes that are important to the population of interest there. There are limitations in the research base due to methodological issues and underlying research studies in the systematic reviews, but we're all methodologically, we're all working on that. Certainly, we need higher quality studies with larger samples and longer follow-up. Most of us know that these short, in 12 weeks I did this and all is fixed. When we go back and we've looked and followed people for 6 months, a year, 3 years, my personal area is weight management, and I just can't tell you, I just get so frustrated at those 6-week studies on, we can all get someone to lose weight, in 6 weeks. So now I'm going to talk about some work in terms of what we're learning about the brain and how we might want to rethink how we give information to people. As I said, I have a center that's funded by NIH, and we're examining brain behavior connections under underpinning effective self-management. So I do want to say that I'm not expecting that in the future, I'm a researcher, I'm not expecting in the future, I'm a behavioral researcher, and I didn't start out studying the brain or doing fMRIs. And I certainly clinically don't think we're going to be doing fMRIs on everyone. So we're looking now, using fMRI as a tool to look at brain patterns associated with people's reactions to different kinds of information. I expect that in clinical practice, and this is what I'm working on now, we're going to develop the questionnaire of 4 or 5 questions, hopefully, that you'll use in an assessment that will tell you how that person processes information, which we don't get at it at all. We assume we're going to give them the information. We give them pretty much, we expect them to process how we did as health professionals, very analytic, and which actually we don't do that. We're not that analytic when it's us sitting in the chair. I just want you to say, even though I'm giving fMRI information, that's not what we expect. But the brain patterns that we're finding, the phenotypes, the brain signatures are what's going to be important. So I'm saying, what if we could identify the ideal self-manager by thinking about a particular brain pattern that they had? We are using fMRI, and I want to say that this slide particularly shows, if I can show you here, okay. The light area, well, we'll go back, okay. The orange areas here are the empathic areas of the brain that process emotion, how we value things, self-referential parts of it. The blue parts on the blue shades here are the analytic thinking parts of the brain. Okay. Now, I'm not naming only brain regions because we found out they're networks. They're different brain regions that are across different areas of the brain. This is, again, just showing this is the what we call the analytic or the task-focused network of the brain. This is the empathic or ethical portion of the brain that are separate. Okay. So our basic hypothesis that we have is that the ability of people to differentiate or their brain to respond, what we found out is there's a normal distribution of how people respond to empathic information or analytic information. Now, that's saying normal, but there's people on both ends of that when exposed to analytic information don't take it in and only respond in an empathic way to it, and vice versa. People who get empathic information and they're looking for the analytic in it. So we have devised a test under the fMRI where we expose people to extremely empathic information. What we have is we have a video that takes about 25 minutes that people watch. They're 23-second clips, 23 seconds long clips that are very emotional, some of the clips, how I felt when I was diagnosed with AIDS, or very analytic, this is how your heart works, okay, just to give you an example. And then we look at their brain patterns as they're exposed to the different types of information. So we, I think we actually call them coping stories that when we give the empathic information or fact-focused information. Then I have some mix because I think some of the self-management information we give could be either. They're not exactly one of the other. Just quickly, I'll wrap up now. We have 9 studies going in our center. We use a common framework across all studies, so we can pull data in terms of all our measures. So we use common data elements. So everybody measures quality of life the same way, anxiety the same way, depression the same way, the brain markers the same way, so we can pull data across them. And we're looking at that. I'm going to just wrap up. This is my last slide now. I'm not going to give you my outcomes today, but I will tell you one of the interesting things we found is some strong associations between the order that you give information to people. If they have empathic information, they've tended, in all of our studies, we measure we do an intervention, we measure task differentiation before and after that. Intervention, and the interventions are giving them self-management information that's either with varying degrees of empathic information in it, how to cope along the way. And then we look at behavior change, and then we look at a health status change, hemoglobin A1C or blood pressure or whatever. So we can actually see how task differentiation of the brain, the different patterns of how people respond to information, whether they're associated with true behavior change or health status change. All right. We think this is one route to precision healthcare. I noticed the person before me ended with the need to tailor, and I think this is one step to an important big step moving toward actually tailoring information for self-care. Thank you.